It takes an incredible concentration of manpower. There's a lot of systems already in place for kidney transplant programs for transplant programs that do living donor kidney transplants. But to run a successful kidney paired donation program, what is required is initially the backup of the system on all ends: surgical, medicine, administrative, nursing, OR, the histocompatibility lab, the blood bank. All ends have to then put in extra over and above what you're already doing. When you first start this, you have to show you're going to be able to do it. So you don't necessarily have initially the resources that you need to. So each person stretches themselves. So you have to have the bandwidth to be able to do that. Then you have to be able to have the volume of patients as a single center. There are not many single centers around the country that do kidney paired donation. Most of them do it with other centers. We're probably one of 2 or 3 in the country that just does it as a single center. And to be able to do it as a single center, you need enough patient volume. So we have to have about 40 to 50 incompatible pairs to start having good matches show up to be able to then get creative and do these transplants. So UAB being the volume center that it has, we have 3,500 patients waiting on the list, and we have about 1,000 phone calls a year for potential living donors. I want to give a kidney to X. So out of those 1,000, we eventually get down to about 150 to 200 transplants. And a lot of them are sort of medically not suitable, or they're not compatible. So the not compatible, 35 to 40% is where we get our patient population from. We'll see the recipient first. And then once the recipient is approved, if they say we have a donor, then we bring the donor right away to clinic.
Okay.
When the donor comes to clinic, they get their medical evaluation, but they also get their blood group evaluation. We also do this cross-match test with their own recipient. If they're compatible, if they're medically suitable, then they get approved. But if they are not compatible and medically suitable, then we offer them the options. We then look at every donor-recipient pair and say, is there any way that donor can give to that recipient, even if they're not compatible, by enrolling in the incompatible program and undergoing desensitization? Or is it better for us to find them a compatible pair in the paired donation? And there's an algorithm for who's likely to find a compatible match or who's unlikely to find. And the governing rule for all of this that we all believe in, that I absolutely champion, is that a compatible transplant is any day better than an incompatible. So we do whatever possible to get a compatible transplant first. If you're not able to find that, then the second question is, compared to the pair that they have and the degree of incompatibility they have, can we find them a match that's far less incompatible, still incompatible, but not as bad, much low-hanging fruit, so we can safely and successfully intervene and convert that into a kind of transplant?